Now we're moving on to Smith-Lemli-Opitz syndrome dental and craniofacial findings and behavior management in the dental setting. And for that, we have Dr. Isabel Chase. Dr. Chase is a board-certified pediatric dentist and an assistant professor at the Harvard School of Dental Medicine. She completed her dental degree at Dalhousie School of Dentistry in Canada in 2000 and pediatric dental specialty at the University of Rochester and Eastman Dental Center in 2002. Dr. Chase joined the faculty of Boston Children's Hospital and the Harvard School of Dental Medicine in 2006. She's the postgraduate program director in pediatric dentistry, and in the past 23 years, she's taught over 85 pediatric dental residents and over 500 dental students. Outside of teaching, Dr. Chase provides patient care either in the clinical setting or the operating room with a focus on the management of young, anxious patients and patients with special health care needs, with a particular focus on children with autism and Down syndrome. She serves on a number of committees, including the Sedation Executive Committee at BCH, the exam committees for the American Board of Pediatric Dentistry, and the Royal College of Dentists of Canada, and on both the Council of Clinical Affairs and Evidence-Based Dentistry Committees for the American Academy of Pediatric Dentistry, and is a member of the Determination Panel for the Non-Discrimination Anti-Bullying Committee at Harvard School of Dental Medicine. Outside of work, she enjoys running and spending time with her husband, 2 children, and 2 dogs, and now spending some time with us. Ladies and gentlemen, Dr. Isabel Chase.
That was an embarrassingly long. Had I known you were going to read it, I would have given you my abridged version. So thank you all for hanging in there on this gorgeous Friday to listen to me talk about my favorite subject, teeth and kids. In order just to give me a little quick synopsis, just the green button will go forward. Okay. Thanks all, and thanks for inviting me. I'm really honored to be here today. Thank you to the Smith-Lemli-Opitz Foundation and having me here and dealing with the difficulty of getting my slides. But it looks like you did it, so I'm really excited. Please stop me if you have any questions. I tend to talk fast and have a bit of a Canadian accent, so hopefully we can be a little interactive. I did want to start and just ask, hands out there. Are there parents here today? I think there are some. Hands up. Great. Any dentists in the audience? None. Wow, okay. And then I think a lot of physicians, nurses. Okay, awesome, great. So I just want to tell you I have no disclosures, neither I nor my immediate family, that would pose any conflict of interest today with the slides I'm going to show you. I do have some images in here. I tried to block name brands as much as I can. If you have questions about ones I recommend for my patients, we can come and talk on the sideline after the presentation. Hopefully at the end of this talk, you'll be able to just list some of the common oral and craniofacial findings in children with Smith-Lemli-Opitz. Understand the importance of early dental visits, and then talk about what I think some strategies that have been helpful in my practice over the last 25 years in managing children who are anxious or have oral sensitivities, and hopefully by the end of this talk you'll get some ideas as well. I'm not going to go into the background because I think there are people who can explain this a lot better than I can, and just listening to our geneticist, and I'm sure you've gotten your answers from him. So I'm just going to move on, except saying that the phenotypical findings, which I'll talk about today, are often related to the amount of, or the reduction in the amount of cholesterol that's in the body. And so I'll focus on really the dental portions and the craniofacial portions that relate to that. So just some general things I wanted to mention that I'll talk about is many of our patients with Smith-Lemli-Opitz have developmental delays or intellectual disability that may impact the dental visit, but not all. Congenital heart disease that also may affect our dental visits, and I'll talk about that in a little bit. And then also GI problems, in particular G-tube, need to use G-tube for nutrition, or reflux, because those are the main ones in this slide that will affect dental care. All right, we'll jump right in. Craniofacial and dental findings. The picture of this young lady here, you can see mouth is open. Mouth breathing is more common in our patients with SLOS. Small head, microcephaly. small jaw, micrognathia. All of those together can lead to a malocclusion, typically a class 2 malocclusion. What does that mean from a dental perspective? Just means the lower jaw is smaller and often a little bit more back compared to the top jaw. That leads those top front teeth out a little bit further than the bottom front teeth and puts them at a higher risk of dental trauma. We'll talk a little bit about what we can do to help with that in a moment. Other dental or oral findings, a high arched palate, but often around 50% of our patients have a cleft palate. It may not be a large cleft in the middle of the palate that you can see, but it could be further back and just be a bifid uvula, for example. So the little tag of tissue that's hanging down at the back of the roof of the mouth, there could be a cleft in that. It's important to know that because if it's a bifid uvula, the tissues could all be intact and you don't see an actual hole in the roof of the mouth, but underneath the bone may not be intact, and that can lead to some issues as well, which we'll get into in a moment. Crowding of the teeth is not uncommon, as well as missing teeth or extra teeth, but typically missing teeth. In addition, there are some changes in the way the enamel presents in the mouth. The enamel is the white part of the tooth we like it to be whole and intact, but in a large number of patients, both in the primary or the baby teeth and in the adult teeth, we see changes in the enamel of the teeth. They're not softer teeth, but they may be not as calcified, there's not enough mineral in the tooth, and that puts them at higher rates of tooth decay. In addition, there may be early eruption of teeth and calculus buildup. Has anybody told you your child has had tartar on their teeth? Okay, we're going to get into that. So here's an example of that little girl we saw in the previous picture. So when the mouth is open and there's mouth breathing, that causes our lower jaw to change its pattern of growth. And so it tends to grow more downward and back. So that leads to that class 2 bite I was talking about. In addition, you can have higher rates of dental caries, which I'll talk about some of the reasons we see that, but that defect in the enamel, that lack of calcification can contribute to that. We also see in patients with SLOS where the mandible and the maxilla, but mostly in the mandible, you'll see a thickening or a widening of the jaw, which is not too impactful, but I'll get into more of that in a little bit. And then the weakness around the mouth, which the lips don't close naturally over the teeth and you tend to mouth breathe. And that allows our top teeth to flare out a little bit, so you may see, again, top teeth being out a little bit further than the bottom teeth. And that's because they don't have that closure of the lips down around the teeth. And then the buildup of tartar, or calculus, like we like to call it. So I heard the weavers say that the doctor said there was a cleft palate. Doesn't always come with a cleft lip, and usually in patients with SLOS, there's not a cleft lip. It's usually just the palate that's affected. I don't know if there's I don't think there's a light on here. This is a pretty, oh, that looks like a light. Yeah, thank you so much. So here's a fairly large cleft that's taking up the whole hard palate, but sometimes this is completely closed and the tissue right at the back of the throat, that's where you'll see a little bit of a cleft there. And if we see that, obviously, a hole in the palate is going to be more impactful for the child in terms of feeding and growth. But a little cleft in the uvula at the back of the throat could mean that there's an area of the bone beneath that tissue that's not closed as well. And so it's important if a child is diagnosed with SLOS that we actually have an evaluation either with an otolaryngologist or the pediatrician or a dentist, somebody that can actually look at the back of the throat to make sure that the palate is intact all the way down to the tip of that uvula. It's not entirely understood why there are high rates of cleft palate, but there's a few reasons that have been talked about in the literature. One is with the small jaw during embryonic development or when the child's growing. If the jaw is too small, the tongue can't drop down into the jaw space as it normally does to allow it, as we're growing, there is a split in the middle of the palate, and the roof of the mouth just basically rises like a bridge that's rising to let a ship go through. So the areas in the palate, those little bones just rise up and join together. If the jaw is too small, the tongue can't get out of the way and that palate can't move together and close. And so you can have higher rates of cleft palate as a result. There's also thoughts, so cholesterol is needed in order for the sonic hedgehog gene, which is the gene that encodes for sonic hedgehog proteins that are really important in that embryonic period of development, that period of growth for a baby. And if we don't have the correct amount of cholesterol in the body, then it interrupts the sonic hedgehog proteins from helping the palate to develop. So there's some more research coming out exactly around this as well. But what it leads to is you have a hole in the roof of the mouth, and that leads to poor feeding, poor weight gaining and growth, difficulties with sucking. So breastfeeding is pretty challenging, if it can even happen. If the palate is too large of a cleft, then we need special feeding bottles to help the baby to gain and grow. Cleft palate, many children up until about age 3 have had one ear infection. About 70% of kids have had an ear infection, but with a cleft palate, it's more like 97% of kids who have had an ear infection in early childhood. And you do see patients with SLOS having increased rates of ear infections. Even with palatal repair, we still can see long-term kids having increased ear infections. Typically, the palate is repaired, as we heard the Weaver said, somewhere around a year. There's a lot of research looking at early closure, closer to 6 months of age for many children. The goal of waiting to close the palate until a year is that we think we can have better growth of the top jaw, the maxilla, and less issues with the bite later down in the road of how a child bites together. But there is earlier treatments that are being done. There are earlier treatments, at around 6 months of age. In both of the cohorts that they've been looking at in terms of not just with kids with SLOS, but kids with cleft palate in general, if you have an earlier surgery, closer to 6 months of age, you do have more growth restriction in the top jaw, which didn't seem to make a huge difference overall because they're getting treated with orthodontics and craniofacial treatment later on in life. But it did lead to secondary surgeries around the age of 5 for some other issues with velopharyngeal insufficiency. But as the Weaver said, when we delay the surgery, we have higher rates of secondary surgeries because of fistulas, a little hole that remains around this surgical site. But either way, they do need to have this repaired, and typically somewhere between 6 and 12 months of age. This is just examples of 2 bottles that are well known in the market that help with feeding if you have a cleft palate, that patients can use these quite effectively and not have to get a G-tube or some other means of feeding, but hooking them up in a center that is used to dealing with feeding bottles that can help the child gain and grow would be helpful. There's also obturators, little appliances that can be placed in the roof of the mouth that helps close over the cleft that will also help a child to more effectively suck and swallow. This is an example of a bite. This is a more severe example of a class 2 malocclusion, and not all patients will present with such a large difference between the top and bottom teeth, but this is an example of the top teeth being out quite far from the bottom jaw. And this, when we measure the top teeth to the bottom teeth, if it's greater than 3 to 5 millimeters, we know that does increase the risk of trauma or hitting the front teeth if we were to fall, kids who are starting to ambulate or run and be faster. We tend to see higher rates of trauma to the front teeth. In the baby teeth, around somewhere between 2 and 4, and in the adult teeth, somewhere between 8 and 10 years of age. In addition, because of the hypotonia or the weaker muscles around the lips and the mouth, the lips aren't closing down over the teeth, which also are sort of a protective mechanism to protect these teeth. And so this in combination, if we have a patient who has higher bouts of aggression because maybe they can't communicate or frustration, and so head banging, we see higher rates of trauma to those front teeth. And orthodontics can be very helpful when the teeth are out further than the top teeth are out further than the bottom jaw. Missing teeth is common, and so just all of these areas here, you can see the molars are missing. If they're back teeth, it's not so impactful. We know that we can gain and grow and chew well, even if we have one set of molars in the back. So if we're missing the second set of molars, getting implants or extra prosthetic teeth placed isn't always necessary. It may be desirable if you look and you see the spaces, but usually we worry more about the teeth that are closer to the front of the mouth if they're missing. Okay, risk of dental caries. We'll go back to that picture where we saw the brown spot on the front too. So why do we have an increased risk of dental caries? A multitude of reasons. Vomiting and reflux. When acid comes up from the back of the belly and bathes the teeth, that takes the mineral out of our tooth and leaves that tooth at risk for getting a cavity. And so over about an hour to 2 hours, the calcium and phosphorus in our saliva will go back into the tooth after that bout of vomiting. However, if another bout of vomiting happens again, more mineral comes out of the tooth. And so this constant cycle of reflux, acid on the teeth, mineral going back in the tooth, eventually, if the vomiting continues and there's not an option for the mineral to go back in the tooth, then you start to get breakdown of the enamel. That shows up sort of as a shiny patch on the tooth or loss of enamel, sometimes significant enough that you can get a nerve exposure on the tooth and could cause pain, discomfort with eating, So if there's changes in habits, more mouthing on things, seemingly upset when having something cold in the mouth, it's always a good idea to see if there's been some erosion, as we call it, loss of enamel on the tooth. Brushing challenges. It's not easy to brush a little one's teeth. I remember having my son going through the terrible twos at around 16 months, and I'm trying to get a toothbrush in his mouth, and I'm strong-arming him with my legs around his arms and his legs, and my pediatrician husband saying, "You're traumatizing him." But I said, it's more traumatizing if my kid gets a cavity, and I have to bring him into work to fix it. So brushing is not easy. Just like changing the first diaper was not easy, the first bath was not easy, but I will say with persistence, it usually gets better over time, and it's kind of tough love that we have to do it. So, but there are brushing challenges, and a lot of the literature shows that we have, in patients with SLOS, increased amount of plaque and calculus on the teeth, which can contribute to developing cavities. Dental crowding. If the teeth are straight, it's hard to brush. If the teeth are crowded, it's even that much more difficult to brush. And then the enamel defects, which I mentioned. And so we see the higher rates of changes in the enamel in patients with SLOS, and so that can put them at a higher risk of having tooth decay. So all of this together, unfortunately, can lead to an increased risk. We'll get to how we stop that in a moment, because I'm sure you're interested. Calculus is an example of on the left-hand side where the teeth have been cleaned, and on the right-hand side where the teeth haven't been cleaned. And so this is the amount of buildup of calculus that can happen. And so in patients that use a G-tube for nutrition, just not the act of not chewing food or having a soft diet or a more puree diet allows the calculus or tartar to build up on the teeth a little bit easier. And so things that can be helpful for that is brushing. And if you're not eating food, if you're only taking food via G-tube, basically your cavity risk is non-existent. However, your tartar risk is really through the roof, because that natural movement of moving our tongue and chewing helps to reduce the tartar buildup on our teeth. So if you can't brush with a toothpaste, even brushing with a water, the physical act of moving the toothbrush on the teeth will help to reduce this tartar buildup. If you are using a G-tube for some nutrition and getting food by mouth, then you do have still a cavity risk. And so brushing will be helpful to reduce that cavity risk. One of the most common questions or comments I hear from parents is, I don't want to use a fluoride toothpaste because they don't spit yet. Most kids don't develop a really good spit reflex until they're at least 7 years of age. And if we delay use of a fluoridated toothpaste until 7, then we lose the benefits of having that on those new, the primary teeth, the baby teeth, but also the new adult teeth that start coming in around age 6. And so I'll get into some pictures to show you exactly how much toothpaste we recommend, but we do recommend fluoride toothpaste even if you can't spit. And then one of the more common concerns from parents is they just can't find a dental home, someone that is capable or competent or is willing to see their child. They have to drive to a center to have a dental home. And so establishing care really early on in life will be helpful. And starting off, even with your local dentist, would be helpful. But I do know that many parents struggle to find a dentist in their community that can handle a child that's young, but maybe one who has anxieties may be harder for the parent to find a dental home. Challenging dental visits. Has anybody had a challenging dental visit? Yeah, that's a lot of hands. So hopefully you'll get some pearls from this today. So this is an example of an x-ray in a challenging dental visit. And they tried, and that was the important thing. They got to the machine, they tried. the machine doesn't have to go around their head, but they tried. And I think that's, hearing James Weaver say, taking the steps on the river stones through the water and, in a rural river, that's the approach I think we need to take for dental visits for kids with anxiety or sensitivities in the dental office. So Dr. Tierney, I'm sure, can speak a lot better on this in terms of behavior, but there's a lot of behaviors that can happen that are impactful for the dental visit. This research study spoke with parents about behavior in their child with SLOS, and one of the most common thing was aggression. Parental report of biting themselves, self-injury, banging the heads. And so that can happen in the dental visit as well, especially if you have heightened anxiety, if there's smells, tastes, sounds, noise that's just different that you're not used to. And so hopefully we can put this all together to look at sort of the dental issues and how we can manage behaviors and what they need. So I think the first and foremost is just getting a dental home as early as possible. In all kids, we recommend a dental home by age 1, but if you have not had an evaluation or if it's been challenging to have an evaluation of your child's teeth or mouth, really we should get our patients with SLOS in earlier just to make sure that we don't have a cleft palate that has not been diagnosed. And so really, as soon as the diagnosis happens, there really should be a dentist who's pulled into the team to evaluate the patient. What's nice about that is we could do a diagnosis to see if do an oral exam to see if there's a clefting. And then if you're in a major city near a hospital, we can get you hooked into a cleft palate team, which has a whole slew of people on it: pediatric dentists, craniofacial orthodontists, oral surgeons, plastic surgeons, speech language pathology. So we have a whole team of people that can work together to help get the best outcomes for your child. Parental assisted brushing. I can't stress this enough. The earlier we start with the brush in the mouth, the better it will be long-term, both for overall oral health, but also making the dental visits easier, because we often use a toothbrush just to look in the mouth, because that's a little less frightening than a mirror or some of the other metal instruments we may pull off the table, but we'll often just use a toothbrush. Parental assisted brushing, and no one's going to want to hear this, but we recommend it until a child can tie their own shoelaces. Most kids, we don't even know when they can tie their shoelaces because we use a lot of the Velcro shoes these days. But 7 is usually when the manual dexterity has been developed enough that you can brush your own teeth. And if you have developmental delays, as you do in patients with Smith-Lemli-Opitz, that may come a little bit later. I can tell from my own experience in my 9-year-old son, I was still brushing his teeth, and because it wasn't being done effectively. So everybody is a little bit differently in their ability to, develop the manual dexterity to brush their own teeth. But really, parental assisted brushing is recommended until the shoelaces can be tied. Fluoride-containing toothpaste, even if you can't spit. And we just tell you, if a child is 3 or under, a small smear on the brush, and by small smear, like half a grain of rice, just to give you a kind of a visual of what goes on the brush. And don't try to rinse it off. Just keep it on the teeth. Fluoride on the teeth is really helpful in terms of prevention. How do I brush? I have so many parents say, I can't brush. I get it, because I remember strong-arming, again, I can remember strong-arming my son for many, many months. This is my daughter, very cooperative child. And there's a vast difference between children in terms of brushing. But starting earlier, having them watch you brush so it normalizes it for them, and getting them out of the bathroom to brush. Pick a soft rug, the family bed, the sofa, somewhere outside of the bathroom where there's no toilet, no tub, no sink that they're going to fall and bump their head on or bump their teeth on, because that's one of the most common times that we see accidents with the mouth is getting in the bathtub. So get them out of the bathroom, lay them down on a soft spot, lay them down on the ground so you can see what you're doing. They don't need to be by the sink because, again, they're probably not spitting. You don't need to have the water. Wet the brush, bring it out with you. I used to brush, there's a rug right outside of our bathroom. That's where I laid my kids down to brush their teeth. It's much easier to see if they're laying down. If you have someone who's really active, you can do 2-person brushing where you have one person holding, one person brushing, and that's how you can effectively get the brushing done. If you can't do it twice a day, nighttime brushing is the best. Don't do it right before bed because you've just got them all relaxed. Maybe they had a bath and we're all cozy and getting ready for bed. And you're like, now I'm going to brush your teeth. And now everyone's wild again. So maybe time the brushing closer to bath time, or give a little bit of toothpaste on the brush in the bathtub and let them chew and sort of suck on the brush. That distributes that fluoride toothpaste within the mouth. And then after bath time, you can do a quick brush to make sure you got the plaque off the teeth. You don't have to add more toothpaste after they come out. Just the fluoride toothpaste will be there, and you can just do a quick brushing afterwards. Challenges will happen, and it will come and go, depending on the mood, but routine is really helpful. So if you're brushing first, then you do the brushing for your child. That usually helps with developing that routine. There's an example of the size of toothpaste. Crest or Colgate don't like to see that. The big curly cues on the brush that you see, that'll use the toothpaste faster. No need to do this. A little tube of toothpaste will last you a long time. Just use a small amount on the brush. As they get older and bigger, you can swallow more. It's just like any sort of medication or vitamin that we take. It's based on body size, how much you can swallow. Children tend to eat children's flavored toothpaste more often, 60% more than if it's an adult flavored toothpaste. So bubblegum, strawberry, wonderful watermelon, all of those toothpaste tend to be swallowed more and bigger amounts on the toothpaste brush. So even if they are brushing on their own, probably looking to make sure they're using the adequate amount is important. So I mentioned this already, dental home ideally by the first birthday, but a little bit earlier if the palate hasn't been assessed. And if there is a cleft palate, establishing a cleft team. Usually our craniofacial team, our cleft team, likes to see patients on an annual basis following with your regular dental home in between for visits. Typically, we see patients every 6 months. That's because most insurance programs tell us that's what we should do, which is unfortunate. But many children who are developing tartar on the teeth, calculus on the teeth, would really benefit from having more frequent visits, or if they have a higher risk of tooth decay. And by more frequent, I mean every 3 to 4 months rather than every 6 months. Okay. Managing behavior. I put child life on here because we have an amazing child life team, but many places do not have child life. And so I think parents know their child the best. So a phone call with the family or a phone call from the family to the dentist before the first visit to talk about really their goals of the visit, especially if they're an older patient coming from another place. Talk about the goals of the visit. Talk about triggers in terms of, what makes a visit go well, what makes behaviors not ideal. If there's something that we can do to make the visit better, if a patient likes a noise reduction headphones, they can wear those in the office. If they use an augmentative communication device, they should bring that to the office. If they prefer low light, we can dim the light in the dental office. If they like a weighted blanket, a weighted vest at home for sleep, we have those in the dental office. And so you should ask before you come if they can help make those accommodations for your child. It makes a huge difference. So having that conversation ahead of time is certainly helpful. Our child life team will often do these conversations for us and make what we call a behavior plan. So it's there for everyone to see in the chart. But if you are in a rural area and you don't have child life, your dentist, you can just have a conversation with your dentist about how you think that the visit could be made the best for your child. Allow choices when you're able. You're here, we're going to count your teeth. Where do you want me to start, top or bottom? If there's a choice, give a choice. I try to avoid yes or no answers, like, can I count your teeth? Or I'm going to count your teeth, okay? Because I've asked, and then if they say no, I'm still counting the teeth, and I've just broken that trust right there. So we're going to count your teeth. You choose, top or bottom. Or asking if there's oral sensitivities. Any oral sensitivities with tastes, textures? Yes. So I like to ask that of my patients because we can use flavor-free polishing paste, for example. If you use flavor-free toothpaste at home, which there are great flavor-free toothpaste options, well, one that I can think of that I always recommend, or sometimes it's sensitivity to foam, so we can use toothpaste that have less foam. But give choices when you can. Do you want to sit on that chair or that chair? But they're going to sit. Do you want the chair to stay up or go back? Again, we can work around that. Start small and work up. And I think it's important when you come for a dental visit, especially if you've gone a long way, you want everything to be done. You drove 2 hours through Boston traffic. You're here. You want an exam. You want the x-rays. You want the teeth cleaned. I get it. But unless there's something really pressing, if there's been pain, maybe changes in behavior, changes in appetite, eating, we should really get a good exam that day. But if it's not, if it's just to establish care, I think working up and kind of working with a child's ability at that time. Maybe they're having a great day and we can get a lot done that day, but maybe they're nervous today, and maybe we will only sit in that chair, or we'll only sit in the parent chair and we'll just count your teeth today, and that is okay. And then we can come back a little bit sooner and do a little bit more the next time. And if we can start the visit where we're not causing a whole lot of anxiety and holding the child down, I find each successive visit gets a little bit easier. So I start small and kind of work up over time with an introduction. The little one that took the x-ray, that was really great. They probably had about 5 visits to the x-ray machine, and that was the first time the button got pressed. But counting, giving them an end to how long this is going to be. I'm going to count to 10, and then we'll have a break. I find that works really well for many of my patients who have anxiety in the dental clinic. Or shall we count, no, I don't want to count to 10. Well, shall we count to 5 or 3? And so just having that flexibility and working with a dentist that will give your child that flexibility. Consider sedation. If you need to do something and really the child is overwhelmed with anxiety, then we always have the option to do sedation. Something as simple as midazolam in the dental clinic is usually very safe if we use a small amount just for anxiolysis rather than doing any sort of a deep sedation. Sedation gets a little bit higher risk when you're out in the community, especially if there's a cardiac defect or if there's a small jaw and rescue. If the sedation doesn't go as you're planning with a small jaw and or a cleft palate and potentially a cardiac defect, it makes sedation more risky in, say, a rural area. And so maybe finding a sedation that can happen either in an ambulatory surgical center or within a hospital will be a bit safer. And then physical supports. I love weighted blankets. Does anybody use weighted blankets in the audience? Yeah, they're really cozy, right? So I always ask, do you use a weighted blanket or a weighted vest at home? We have a 7-pound and a 10-pound weighted blanket. This is extremely helpful for children that feel anxious in the dental clinic. Years ago, I think many people were restrained and there is still medical restraint when needed, but a weighted blanket gives you that comfort and just helps to calm the body down. Some people don't like it, but many of my patients really enjoy it. That's sort of taken a place of some of these passive restraints. Don't get me wrong, these are still used. This is called the rainbow wrap, and some children do like the feeling of firm pressure and prefer a passive restraint over someone actually physically holding them. These are reserved more if there's an urgent care. Let's say there's been a trauma to the front teeth. You really need to get a brief hold with this to help get a good look and do emergency care. But usually we reserve these just for that. Unless I have a patient, I have one of my patients that wants to be in there, climbs in, and as soon as the wraps are closed, a big smile on her face. And so there are some kids that truly like that feeling of that firm pressure, but I find most prefer the weighted blanket over that. If sedation is needed, like I said, probably a bit safer to happen in an ambulatory surgical center or in a hospital setting, but this can drastically help address anxiety in the dental clinic. And midazolam is the one we usually use. If you have oral sensitivities and you don't swallow things easily, it can either be given through the G-tube or as a spray in the nose, an intranasal midazolam spray. It kind of stings and burns afterwards, but it works really fast. Within 5 minutes, we start to see effects. It can be very helpful. General anesthesia, if you see, so as physicians who are treating patients, you may get a consult from a dentist saying that the patient has dental cavities, and if they're at a young age, we may recommend treatment in the operating room under general anesthesia. And we will typically reserve that for patients who have multiple areas in their mouth that need treatment, rather than holding a patient down or doing multiple sedations where a child's anxiety is removed, but they're not able to still sit still and open their mouth for about 45 minutes for each area in their mouth. then we'll often recommend treatment in the operating room under general anesthesia. It's important to always reach out to our cardiologist to determine whether or not antibiotic prophylaxis is needed. So sometimes your cardiologist will say before your dental visits you should have an antibiotic. If they haven't told you that and there is a cardiac defect, you should ask. But also your dentist should reach out and ask as well. In terms of vomiting, I think after vomiting, people always think I got to brush the teeth quickly, but vomiting with the acid bath on the teeth, brushing right away will actually cause some abrasion from the toothbrush. The bristles, even though they're soft, that physical movement of the bristles against the teeth after an acid bath on the teeth can be quite detrimental to the enamel and push that enamel loss along more quickly. And so usually if there's consistent vomiting or routine vomiting, we say try not to brush the teeth right away. Offer water if you can have water. Take water by mouth without any aspiration. Or even just like a baby washcloth, which is thin, or a gauze, you can just wipe the teeth gently with water mixed with baking soda, a teaspoon of baking soda. And that will help to neutralize the acids in the mouth and reduce that breakdown of the enamel and risk for dental cavities. Well, it's not coming up, I don't think. Questions? Anything I can explain further? Yes. Okay. And the fistula closure was done? Okay. So even after the closure has been done between the mouth and the nose, patients can still go on to have velopharyngeal insufficiency in the back of the mouth. So you can still get episodes of particularly liquids. Do you find it's liquids coming through? Yeah. Do you have a feeding team, a feeding specialist that you're working with to help?
She has a regular pediatric dentist.
Yeah.
Doesn't get a good look.
Yeah.
She has a left-out doctor, but he has the ENT.
Yeah. Probably a good idea just to make sure there's nothing else going on, but it's not uncommon that even after a cleft repair that you can still, in terms of swallowing, but usually oftentimes our speech language folks can help with that. So the feeding specialists that work with that, they can look at feeding and swallow and where the tongue is going, and probably more helpful than the pediatric dentist. Not to throw them under the bus, but so yeah, I think even being part of if you could be seen by a craniofacial team, but probably ENT just to make sure there's nothing else that's going on in there. But sometimes just with that insufficiency in the back, they can still bring food through the back of the oral cavity up through the nose. Yeah.
Thank you for that question. Other questions? We've got one over here.
Do you have any recommendations for finding adult dental care after the behavior issues with the pediatrics is even worse as they're an adult?
That's a great question. So as a pediatric dentist who works in the hospital, I have many patients that I've kept into late, not childhood anymore, but early adulthood. So, late 20s, early 30s, because of the lack of care in the community. It's just hard to refer. Thank you. Hard to refer my patients out. In Boston, are you thinking Boston? Yeah. Yes. Yeah. You did. Yeah. 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 So we have typically what we do after Boston Children's is sending patients off to either Tufts Special Healthcare Needs Program.
They're not accepting patients anymore.
At all. So they told us it's about a 9 to 12 month waiting period. So not at all. So they've closed. Yay. I'm sorry. Darren Dragg is the head of that program. And I would reach out and speak to Dr. Dragg because he has a good heart. And he does take all of the patients that we refer directly to him. Mass General has closed down the dental, not closed down, but closed to new patients for right now because they've shut down or they have very little people in that dental clinic now. And I think, unfortunately, that's what's happened. So most of our patients, we've transitioned from our hospital center to another hospital center. And a lot of those programs, like the one at the Brigham, for example, closed down. And so I'm going to put my plug in for, certainly advocating for patients to maintain those hospital dental programs, because that was sort of our lifeline for where we sent our patients after children's. And a lot across the country have closed down because they're not considered to be lucrative for the hospitals, unfortunately. So outside of that, we don't have private practitioners that we can send to in the community. We don't have anybody that is an open referral source, unfortunately. And so Tufts has sort of been Tufts and Mass General have been our two that we've dealt with. Mass General, I know, completely shutting down to new patients at this time. It doesn't mean forever, but they'll often shut down new patients for a little bit and then reopen as they kind of get control of their current patient base. But Dr. Dragg, if you speak to him directly, I think he has a good heart.
Speaking of a good heart, and before I hand the mic over for this next question, I'd like to remind everyone that Dr. Elaine Tierney has an appointment available at 4:30 this afternoon, so that's coming up in the next 25 minutes. So if one of you would like to grab that. Also, tomorrow morning at 9:30 and tomorrow afternoon at 4:30. If that interests you, then you should head right over to the table and let them know.
Hi, question about the overcrowding. What's your recommendation on pulling extra teeth? And around what age?
Yeah.
That's just for general question. My sister is 56. She is older, and my parents chose not to pull some of her teeth. I think she still has a long life ahead of her. She has very extended front teeth. Would you recommend doing some extractions now or just let it ride?
This is a good question. Without seeing it's hard for me to say, but I'll give you sort of without seeing her, it's hard for me to say exactly, but without seeing her, there's some things that I think you could potentially do. First of all, orthodontics may not be something that your child can tolerate now or in a year, but maybe 2 years or 5 years or 10 years. And although you looking at the teeth and you want to bring the teeth back a little bit closer into the mouth, there's no end of when that can really be done. It could be done at any time. And we see a lot of patients getting, they're all in braces at 9 these days. But it doesn't necessarily have to. It's not like you're behind the 8 ball and you have to get braces done at that 8 to 12-year age that you see all of those braces being happen. So at 56, you said your sister's, you could still have braces at this point if that's something that she wants and can tolerate. So I just want to put that out there, that don't feel pressured as a parent to say, oh gosh, I needed to have braces on these teeth. They needed to be done yesterday. We need to have this fixed, because you can work with comfort level for a patient, because it also makes it really hard for parents to brush if you're the primary brusher for this child to then put a lot of metal hardware in there. I will say that some of those Invisalign, like the plastic retainers that go in the mouth, multiple different ones over a course of usually 2 years, that has helped a lot of my patients, not particularly ones with SLOS, but my patients with Down syndrome, for example, that were unable to tolerate the feeling of the metal in the mouth. So there are other options that we can do. The other thing is it doesn't have to be the full meal deal or nothing. It can be, if you find an orthodontist, like one of our orthodontists, he will do very limited treatment. If your concern is these 4 front teeth, I don't like that these are out 4, can we just bring those back? So you can also work with dentists to say, I would really like to have limited treatment just to correct this. Can you help me with that? Because I think, again, there are options that you don't have to do everything all at once yesterday, So going back to the question about teeth and crowding, if you have a cleft palate, the reason that we delay care until usually 12 months is we usually say the top jaw will allow it to grow a little bit wider, and by better I mean wider. And if you close that palate too early, we get more constriction. But even if we wait until 12 months and we close the palate, there's still constriction of the top jaw. That contributes to that crowding. And so usually the best treatment if there's been constriction of the jaw is to make the jaw wider rather than taking the teeth out around the jaw. You may need both things done, but oftentimes you just need the jaw expanded. So our craniofacial orthodontist could speak to this for days, but they usually do some sort of an expansion appliance in the mouth. That one does have sort of some time limits when you do an expansion appliance in the mouth, because I guess I shouldn't say that. You have different effects depending on the age that you put it in. If you put it in younger, you get more palatal expansion or expansion of the actual jaw structure, versus if you put it in later in life, you get more tipping of the teeth. Either way, it's going to help to address some of the spacing issues with what looks like crowding. Appliances that expand the jaw are not easy. It requires, most of them, up for the parent to turn a little screw in the middle of the mouth, at the roof of the mouth. It's not an easy screw to find. It's not an easy task to do. One of our brilliant dental students has worked with his dad and developed one that you don't have to do that. So that is coming along, and so that will be very impactful, I think, for a lot of families. You can, though, if there are some teeth that just are out of place and you don't really want to go through orthodontics, you can do removal of teeth just to help address some of the crowding. Typically not front teeth, but sometimes side teeth. The only thing is, if you remove teeth without some sort of braces component or Invisalign component, then you probably are going to be left with spaces. And so we try to avoid that if we can, especially if there's a nice smile. Even if there's crowding and there's a nice smile, we try to preserve that. Does that answer your question?
So we have two live stream questions. I'll read the first one off here. Denise Moyer is asking, Whitney tolerates brushing very well, but we've never mastered flossing. Any suggestions or techniques that might help?
How old is Whitney? That's only because I'm going to say it depends on how old, because we only recommend flossing to start when the teeth touch. And so for some kids that could be 2 where the front teeth are crossing, but sometimes teeth don't begin to touch until they're 4. And so I think brushing is the first and foremost the best thing I want. It's great to hear that she's brushing and tolerating brushing. Those little flossers, the little floss sticks, those are really helpful. They're not great for the environment, but they're really helpful in terms of flossing for parents. And just like everything else, it doesn't all have to be done at once. I have a few families, they brush floss this part of the mouth one day and this part of the mouth the next day, and they break it up and they work with what their child can tolerate. So although we say we'd love for you to floss every day, consistently, every day, once a day for flossing, if you can't, then floss as many teeth as you can during that one session of a day. So and then start in a different place the next time, so that throughout the week you're getting multiple areas in the mouth flossed. I'm sure many of my colleagues will kill me for saying that, but honestly, I'd rather you do some than none at all. And again, if you can floss different areas of the mouth over a few successive days and then start over again, that will be very helpful. But I find most of my families really find that the little floss sticks are very helpful. And then have their dentist show them how to get in there. Most parents, not critiquing you, come from the front to brush, right? So the best way to brush anybody's teeth is to come from behind. Either lay them down or tipping your head over or leaning their head back on your lap. That's the easiest way to see. But also helps to cradle the head a little bit. So if you're leaning back and cradling the head or laying the head down, just like in the dental office, it's a lot easier to see than coming head on, where you're using one hand and maybe the head is moving away from you while you're brushing, and then you can't lift the lips or pull back the cheeks to see, so you kind of brush the tips of the teeth, but you don't get up close to the gum line where we really need to brush. That's where the tartar tends to build up. That's where the gums bleed. So by lifting the lips so you can see the gums, you can really only do that when a patient is lying down or sitting in a chair, that you can kind of access all of that. Otherwise, brushing like this in the front, usually a head will move back, and you can't really brush at the same time as lifting the lips. It's really challenging. But flossing the same way. If you're laying back so you can actually see where you're going with the floss, it's much easier to tolerate.
Okay, and then another online question from Kayla Kempster. Hello, we live in the UK, and the doctors here are not intending to repair our daughter's cleft palate due to being nonverbal and not eating orally. Is not having her cleft palate repaired likely to impact upon her dental needs either now or in the future? Elise is 7 years old now.
Yes, absolutely. You know, having an intact palate helps with speech development, and it helps with the ability to learn to feed. And just because she's not feeding now, maybe she'll feed later. And I see many of my patients that have been nonverbal when they started with me, on a G-tube and not eating, and now I've seen them for the last 20 years, and hi, Dr. Chase, and they're eating a full meal, and so things change, and growing, you know, with the palate not closed, yeah, I don't think that's ideal. Yeah, that's my personal opinion, but I think we can back it up in some good evidence that it's important to close that palate.
And then a third question came in the meantime. Millie is asking, do you have any recommendations for toothbrushes for kids with oral aversion? She fights anything in her mouth, and even though she is only 3, she is super strong, and she usually wins the fight.
Oh, persistence. It's tough. Yeah. So I'll tell you, there's a brush that you can purchase, and I forget the name of it, but it has 3 bristles. Bristles on 2 sides and then a bristle on the top. What's that? Yep. Yes, exactly. Yep, with the brush on the top. That is helpful. It's a bigger brush, and it's a little awkward to get in there in a really small mouth. But I would encourage either the use of that or starting slow, using a really tiny brush. And starting with the outsides first, top and bottom. There's some, you can either make it your own, you can buy it. I'd probably just make it your own. To hold the mouth open, just stacking a couple of tongue depressors and putting a little medical tape on the end, so you have like a little soft spot for her to open on. Holding that between the teeth will be really helpful as well. Biting on the brush is okay. It probably doesn't make it so easy to move around, but even having your dentist show you, we have a little trick where we put our finger in the back of the mouth that helps to open up the jaw, and their dentist should be able to show them how to do that in order to access the teeth on the inside, and to put that little set of tongue depressors between the teeth to help brush the insides.
Thank you for those online questions. We've got one over here. Thank you.
I just want to verify that with the cleft palate. So the submucosal cleft palate also should be repaired?
So only if there's issues. So if a child is making speech sounds, if there's a submucous cleft, you can have hypernasality with that. You can have ear infections with that. And you can also have regurgitation of food through the nose. So if you have a patient who's coming in and saying, parents saying, oh, the speech sounds really nasally, or bringing food through the nose, then it's a good reason to repair it, yes. And also, if high rates of ear infection is also a good reason. Yeah.
Thank you.
Depends
Another
on the size,
question?
too. Sorry. Yeah, sorry. Go ahead.
Another question? Hello, Kate.
So Andy and I brush our 24-year-old son's teeth just as you described, with his head in our lap, and we play like dental hygienist with the Sonicare toothbrush, and we go for 2 minutes, 4 minutes,
Awesome.
and he's very compliant because we picked that battle from almost day one. But he now can only get hospital dentistry with general anesthesia like every 3 years. So, and of course, that's awful. And we just sort of wonder, is there more we can do during that 3-year period than the everyday flossing and brushing?
Yeah. Is someone telling you he can only do hospital dentistry, or?
They're saying the risk isn't worth it.
Would he? If he's tolerating a Sonicare brush, he should tolerate a regular dental cleaning brush. Does he, or not? No.
There is no way he would get in a dental chair in a dental office. Absolutely no way. No.
I say this with tongue in cheek, but are you sure?
100 freaking %.
Have you ever tried bringing the Sonicare brush to his dental visit?
Oh, we've tried. We've tried it all.
Yeah.
Really. Because he's
What-
24.
What about sitting in the parent chair rather than the dental chair? Would he sit?
Oh, we've done.
You've
oh,
done
no.
all that.
I'm going to introduce Juki to you. Yeah.
I've seen it all, and I've done exams on the floor, in the corner, in the front waiting room, and all that. So, and I don't want to minimize what what you're saying, but every 3 years is a long time. However, if he's not had issues in the past, meaning no dental cavities, and it sounds like excellent oral hygiene, then he probably has minimal, if any, tartar on the teeth. Then it's probably okay. Especially if you're doing it. I think most of it is home care, and I always say that to parents, like, you come to see me, and I put on the fluoride that we put on, and take the calculus off the teeth, and those are probably the two most important things I do for the patients when they come in. 99% of it is home care, but home care can be really challenging. I can appreciate that. But that's really the most. It's diet control, it's the brushing, and ideally some sort of a fluoride application to the teeth. But diet's a tough one because sometimes to deal with behaviors, maybe we'll use food as a reward or as a motivator, and sometimes it's small, sticky, and sweet, like Skittles, things like that I find are sometimes used in ABA therapy, for example. And that could really, put that dental decay level through the roof. So most of it's home care. It sounds like you're doing a great job at home.
Is there a certain fluoride application that you recommend? Like, we get the varnish, of course, every 6 months for the rest of us.
That's great.
But we don't have access to that.
No, and you don't need it. Really, all of the literature really supports low level, high frequency as being the most effective. So having a fluoride toothpaste twice a day is the most effective, and more effective than just doing, say, high-level fluoride in the dental office. That is the most effective. That in combination with diet control, watching frequency of number of times we're eating carbohydrates. So even if it's not candy, things like chips and bread and cookies that stick in the teeth ultimately break down to sugar. And so that can be quite impactful for many patients.
I propose that we bring Juki up on stage and I just show everyone how I brush his teeth every night. But that was vetoed.
That would be really helpful for parents.
Yeah, that would be great.
Because, yeah.
So what do you do in the situation where as soon as your child sees a toothbrush, he makes himself puke?
Mm-hmm.
We go, no matter where we go, you even for us, if we even get our toothbrush and he sees it, he makes himself vomit all over the place, and it's a great mess.
What about brushing with something other than a toothbrush? Like wiping the teeth even with like a finger brush or a washcloth?
He'll puke.
Yeah. Anything in the mouth, you mean?
Yes, he will puke. Mm-hmm. Even if he will make himself throw up to get out of school. Mm-hmm. He is a smart little booger. He does it to get out of everything, and we give in because, well, the one pediatrician has discharged him from her care because she's afraid of him because he pukes so much.
Yeah. Well, after the one puke has happened, is there anything left?
No, it keeps coming.
It keeps coming.
I just don't do it.
Yeah.
Marty?
It's not a question, but I'm afraid I'm the poster child, a bad example of parenting. Although maybe the risperidone helped decay my daughter's teeth. Plus, they didn't come in all the way. And then she would grind her teeth when she was 4 or 5. That was just awful. We couldn't stand it. But they've all been pulled now. There's a few on the top. And she kind of looks like a kindergartner because they took the front 4. but they're gone. And so fight however you have to get them to get their teeth clean, the Juki angle or whatever it takes to get in there. I know I was suffering from severe depression for a while, and I think there was a time she loved strawberries, and I'd let her go. I didn't even bother to brush her teeth at night and think of the acid in strawberries. So I just stay on it, stay on it. She used to have a beautiful, bright smile, and I still think it's beautiful, but there's nothing on the bottom.
Yeah, yeah. I think getting the care early before you can develop that aversion to the toothbrush is so important. So getting young patients into that pipeline so early on. Often we don't see first dental visits till 5 or 6, and by that time, unfortunately, then we're dealing already with some issues. Now we have to do more intense or, I guess, more invasive treatment at that point than if we see them just as the teeth are coming in, and we develop a routine where we see them and they get comfortable and build some trust. Usually that's a lot easier for families and children if they see us earlier rather than later in life. It doesn't help with the puking now, unfortunately, but it could help for kids to make it a safe space, because if we only have episodic care or emergent care where we're taking teeth out, obviously those visits are always going to be a bit harder and more challenging, both for the parents and for the child. But if we can have primary prevention, meaning seeing them before anything has happened, then those are the kids that usually do a little bit better in those dental visits.
Our dentist automatically just throws them in the operating room. That's what we do. Yeah, once every 2 years.
Yeah.
Can you recommend any toothpaste that's not mint flavor? That's a good one.
Yeah, so Flavor Free, Ora Nurse, O-R-A Nurse, makes it's a red packet with white labeling. You can get it on Amazon. It's flavor-free, completely flavor-free. And then Tom's of Maine makes 2, Tom's of Maine with fluoride, Tom's of Maine without fluoride. Choose the Tom's of Maine with fluoride. They have watermelon, strawberry, I forget the other flavors. And a lot of my patients love it. And the nice one about that one, it has reduced or no SLS, so sodium lauryl sulfate, which is the foaming agent, so it foams less. A lot of kids with oral sensitivities just don't like the feeling of the foam. It's not the taste, but the foam. And sometimes it's the taste and the foam, and sometimes it's just the taste.
So I know Boston Children's not big on sedating unless they really have to. What are my other options? Because when he goes in, it's traumatic for him, but also traumatic for me because it's horrible to watch him scream while they try to clean his teeth. And they want to see him every 3 months.
Yeah. So increased frequency sometimes is helpful for kids. It makes visits a little bit, there's less to do on each visit. It makes it a little bit less upsetting for a child, but it doesn't work for everyone. And so I have patients that I sedate every 6 months when they come up to see me. They get a little midazolam in the nose. We have a regular dental visit, and they go home that day, and that's it. So I'm not sure who's taking care of your child, but I happen to be one of the sedation providers, and if a child needs sedation, we sedate. It carries greater risk as soon as we sedate somebody, right? As soon as we give a medicine that they are not used to taking, it could increase the risk of having something happen that wasn't planned. But if you're using a small enough amount and you're using it just to sort of take the edge off, that can be very helpful, and that is something we can do. And it's not, sedating only if we have to sedate. Sometimes we think what we're doing is not so traumatic for a child, but again, you know your child the best, right? If they're so anxious after and their behavior's terrible after that visit, and you're working for hours after just to calm them down, then your child needs to be sedated. And that is something we can do.
I think all of us wish that we either lived in Boston or had such a dentist as Dr. Chase in our hometowns or cities. Let's give her a round of applause for an excellent presentation.
Thank you all. Thanks for your great questions. Thanks.